to Dr. Vettendos, as a respiratory physician to oncologist. All the evidence you showed is that targeted immune therapies beat chemotherapy,
Yes.
cytotoxic therapy, left, right, and center.
True.
So why the hell you're still using it and make the patient sick?
Because when you look at those, first of all, it is moving to, if we have access to it, it should be moving to first-line use of immunotherapies, at least in PD-L1 positive patients. There are two problems with that. One is that not everyone will benefit from immunotherapies. If you look at the curves, although we have improved, but there's still a considerable number of those patients who will progress early on. We don't know why, but hopefully we'll find out. Secondly, it's not possible to sort of, at least in the current environment, accessing these drugs is a major issue, both for health systems and secondary for our sort of treating physicians, because each one of these drugs will cost probably around $100,000 a year, and it would be very difficult to sustain the health system this way. Same goes with the new generations of ALK and EGFR mutation inhibitors as well. But it's a space to watch. I think that the whole treatment of lung cancer is evolving very rapidly, and in a couple of years we'll be using immune therapies first line.
Gary Anderson, I'll just bring the microphone to you.
They were really great talks. For Dr. Silvestri, I was recently at the COPD Gene scientific meeting, and the colleagues there were discussing the role of advanced imaging, both for enriching the probability of in screening programs, but also in the management of early nodules.
Yeah.
So I wonder if you could comment on that, and also the advances in Avi Spira's work on gene profiles in the nose, for example, that seem to be predictive of risk.
Yeah, so that's a lot in there. Let me also start by saying that was amazing, and so I'm going to defend my oncologist here and say two things. One is, the one paper he sort of perfectly showed was Mark Chris's work, which showed that there's 17% of patients have EGFR, and there's smaller patients with otherwise. The one thing that's in that study that's amazing for pulmonologists to think about is this. 10 or 15 years ago, we were basically saying nothing works in lung cancer. Why are you guys still doing this? If you look at patients out of that it was called the GO grant of Mark Chris's work, 1,000 patients got completely genetically profiled. If you had a target and you treated that target, their survival was 3.5 years. 3.5 years. If you had a target and you weren't even treated for that target, it was 2.5 years. And if you didn't have a target and obviously got traditional chemotherapy, it was about a year. So we're seeing massive changes in survival to the point where now about 15% of stage 4 patients in the United States are living 5 years. And so I think we've got to, as pulmonologists, get our heads around the fact that we're seeing amazing changes in the oncology community, first time in my 25-year career. Now, let me get to your question. The first, which was the gene profiling story. And so Young's work out of New Zealand and some others, I think there's something there. First, let me get to the radiomics piece. So the first part is, how are radiomics going to help us? That is using really advanced CT, PET, these kinds of things, going to help us to help either in screening or, more importantly, in nodule evaluation and management. So let me try to get my head around it by explaining the answer in a couple of ways. We have all been working in silos. And so they're the prediction modeling people, the Swenson criteria for predicting cancer and pulmonary nodules, Tamamagi's models, et cetera. They're like in one section. And they peripherally use a little bit of radiomics, but not much. Then there's the radiomics people, and so Mick Williams and others have looked, and from the Nelson trial, have looked at volumetrics, which I think is absolutely the wave of the future. I promise you. This idea that we can take a cursor on a thing and go, well, this is the diameter of the nodule, start here and end it here. There's already been studies that have shown it's wildly inaccurate, but if we could have the computer look at all volume, it's incredibly accurate. So we have the volumetric people over here. We have those. Then there's the biomarker people, and we've been working in our lab on some blood biomarkers to predict cancer or no cancer in pulmonary nodules. I finally like put a slide together that has all these satellites and sort of, I saw one of these TED Talks on deep machine learning and got fascinated with it about 5 or 6 years ago, and I started peripherally working with the IBM Watson people. And what I think the answer to this question is we need to get all this data together in one place and have a machine tell us, like, look, we should be able to tell within a 5% accuracy what's cancer and what's not in the nodule. And I totally agree with you. I think radiomics is going to help us get there. Biomarkers are going to help us get there. Regular prediction models are going to help us get there. And it's not that hard, just plugging all this thing into a deep machine learning algorithm. I think that's coming, and way faster than you think. I think it's coming pretty fast. Avi Spear's work, I don't know if you saw, I published the article in the New England Journal on the brushing, the bronchial genomics brushing. Avi was senior author, and I was first author on that article, which showed that normal epithelium expresses genomic alterations consistent with cancer versus no cancer. And so if you're out doing a bronchoscopy on a peripheral nodule, and it's non-diagnostic, and you just do a brush at the carina of normal mucosa, you can see genetic alterations which will tell you whether or not the patient has cancer with pretty high predictability. The problem is, who wants to go through a bronchoscopy for a small pulmonary nodule? We know that bronchoscopy is just not that good for that. So in that same trial, we did blood testing and nasal swabs, and Avi just published that data on nasal swabs in Journal of the National Cancer Institute, showing that even just the DNA from epithelium of nasal swabs is pretty accurate at predicting cancer. I don't know if that's going to be the final. So is that good? Yes. And if I'm doing a bronchoscopy, by the way, and I don't know that I'm going to get an answer if I'm doing an E&M guided bronchoscopy and we don't know whether we're getting an answer or not, I'll do a brush and send it off if it's non-diagnostic. But that's not really the way to go. And I'm not even sure nasal swabbing, which, by the way, is really uncomfortable, even in the bronch lab for patients. I still think blood biomarkers probably going to win out in the end, but don't hold me to that because I just don't have enough data yet. Long answer. Sorry. Is it helpful?
That was a great answer, and it probably answered quite a few questions. Perhaps I could actually ask a question which actually links the two talks. Do you think nivolumab will help lung cancer screening?
Do I think nivolumab is going to help lung cancer
and
screening?
The subtext of that is nivolumab is horrendously expensive, and it will actually set the bar at a different level. Yeah,
so I started with the cheapest thing we could do is get people to quit smoking, followed by diagnosing them. You know, what's interesting is stage 4 lung cancer is more expensive to treat than, by the way, with or without treatment. Even if you do supportive care for stage 4, you're going to start running into medical costs related to supportive care, palliative radiotherapy, hospitalizations for other things. So I think, you know, just the treatment of stage 4 is very expensive. Do I think that's going to push screening along? I don't know. I think screening's got implementation challenges. Remember, this is the first time we're going to be directing a screening study at a particularly poor behavioral health habit, namely smoking, and we don't know if we're going to be able to capture that population or not. Is it going to lead people to want to do more screening? Absolutely. Where I thought you were going was, could we introduce not nivolumab, but a biomarker into the screening algorithm, and where would you introduce it? So the first thing is you could say, look, what if I had a biomarker that predicted cancer, no cancer, a blood biomarker? Maybe I should introduce the blood biomarker first, and if that's positive, then go on to screen. And if it's negative, maybe they don't get screened. They just get smoking cessation counseling. So that's one place to introduce it. The other place is obviously after you have a nodule from a screen, then introduce your biomarker. I think that's where the science is going, where to introduce a biomarker in the screening algorithm, because we know screening is pretty sensitive, but not very specific. We have tons of false positives. If you could introduce something that's pretty sensitive upstream with a good specificity, you might want to do that. So that's where I think it's going. One other comment I meant to make about your talk about interstitial lung disease are related to, and this is specifically for pulmonologists. We have seen severe, life-threatening ILD from the immunotherapy group to the point where even if it's stopped, even if the drug stopped and they're put on steroids immediately, they die. And I'm telling you, I've seen now 3 patients in the last year. It's horrible to watch. The immune reaction stays going on and on. These people can get debilitating arthritis, colitis, and interstitial lung disease. And what I would just ask pulmonologists to think about is if you're seeing patients who've been on the Nimolab and they've been referred back to you because they're dyspneic and they have interstitial lung disease, our first thought is, could it be infection, right? Or could it be progression, right? And we always throw pulmonary embolism because that's what we do. But I would ask you to think about immunotherapy, interstitial lung disease. And by the way, that also is the same for traditional chemotherapy. 2 to 4% of our chemotherapy trials have a chemotoxicity and pneumonitis from chemotherapy. We need to think more about that as pulmonologists, absolutely. Because if you don't stop that therapy quickly, these patients can die.
Sorry, Gary, maybe last question for the session.
He's the only guy in the room interested in lung cancer, though.
So we saw this year that the MYSTIC trial, which combined a PD-1 attack with a CTLA-4 attack, was more toxic and not as advantageous. But there are other strategies to try and improve the depth and breadth of IO cover, such as targeting IDO. Could you comment on these adjunctive strategies that are being used trying to push the IO benefit?
I didn't quite get that. So you mean other targets in conjunction to PD?
Like IDO. So the,
Yes. No, in melanoma.
Sorry, for people who don't know IDO.
So it's a small molecule released in the immune context that has an immune suppressive property.
Yes. So there are works being done in melanoma, and very soon it will translate into other immune-sensitive cancers like lung cancer and bladder cancer later. So melanoma is spearheading this because when you look at the sort of genomic instability, melanoma sits first, and then lung cancers. They're probably a couple of years ahead of lung cancer, but that will certainly translate into the area. The other thing that I wanted to mention was the role that microbiome is starting to find in both immunotherapy and potentially later in any sort of translation of why the cancer behaves this way in different people. Obviously, you probably are aware of the gut microbiome and its effect on the immunotherapy response rate. So why some people respond better, some people don't. Looks like there's a lot more to it than just the cancer and the receptors and looking at the immune system itself. I'm quite interested to see if there's any data around microbiome of the respiratory tract and lungs that may affect the response to immunotherapies, especially in lung cancer. I think we tend to simplify things because that's how our brain works, simplify it so we can understand it better. But the whole of sort of the organism needs to be sort of taken into consideration when you think about why there's so much difference in behavior of different cancers in different people.
And we'll just give Dr. Silvestri one last comment.
This is just another plug for the oncology community, and whenever I get a chance to talk to pulmonologists, I'll tell you, you are going to be asked to give more and more specimens for the exact reason that you saw up here. So we do a lot of EBUS at our institution. I write a lot about EBUS. Please get them, if you're doing EBUS, please get them 4 to 6 extra specimens in cell blocks so that they can into Hank solution so that they can look for all these different markers, because if we don't, we're going to lose that space and they'll be going back to mediastinoscopy. So let's have you guys think about that. If the patient's already on the table and you're getting 2 or 3 specimens, nothing wrong. I'm taking 6 extra specimens once we have cytopathology telling us we have cancer and putting them straight, not staining them, putting them straight into Hank solution for cell block. Meet with your pathologist, talk to them so that you can get specimens because they need this to do their job. We wouldn't think of treating breast cancer without knowing HER2/neu and ER/PR status, and we do this in lung cancer all the time, at least in the United States. Not here, everything's better in Australia. But anyway, I thought I'd just mention that if I could. Thank you so
I think
much.
it's probably a good point to finish. So thank you very much. 2 excellent talks, 2 great speakers. Appreciate your attention.